As you can see from your notes, there's like 150, 160 slides, and the abdominal imaging component of it is a big part, and there is a lot of interrelation between all the different body systems, okay? You can't talk about the gastrointestinal system without covering the hepatobiliary, without covering the genitourinary, without talking about vascular and blah, 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 blah. So it's actually kind of a challenging region for me to explain to you meaningfully and very, very exactly. So we're going to do it by body system, but there's going to be a certain amount of me saying, and we'll talk about that next week sort of thing. So what we're going to start off with today is the absolute basics. We're going to spend just a little bit of time learning a very easy x-ray, learning the AP abdomen x-ray, and about 20 other projections that you're going to do are all going to be slight variations of that one. So we will make sure that we can get that one down pat, and then from there we'll branch out. So whenever we start talking about the abdomen, we need to recognise that there are going to be a whole bunch of people involved in this patient's care. There are going to be radiographers and speech paths and nurses and surgeons and gastroenterologists and all sorts of people there. So as I've mentioned in the past, it's time for us to move away from the idea of this being this one-on-one care. And yes, I want you to still take ownership of the examination. Yes, it's still your patient. But what I want you to do is to get into the mindset of recognising that you are part of a chain of people, part of a team of people who are involved in the best care for this patient. You are an expert in what you do. Your advice and your knowledge is valuable and should be respected as such, but similarly, the other people involved in that patient's care are also worthy of your respect and time. So a lot of the abdominal imaging is, once again, as I mentioned earlier in the semester, we're going to be moving away from the idea of this is the exact criteria and this is when an examination is done, and rather it's going to be talking about the aims of the examination, and those aims of the examination are going to be based around the pathologies that we are investigating. All right. So when we have a look at our abdominal body systems, we're going to be splitting it up in terms of our lecture material in these 4 stages. So gastrointestinal, which is going to be probably the biggest component, genitourinary, slightly smaller, hepatobiliary, smaller again, cardiovascular is going to be threaded all the way through it. So as mentioned there, no single modality is necessarily going to be the best examination for some pathologies, and indeed we have a lot of small changes taking place in how we do our abdominal imaging nowadays, as both particularly MRI and ultrasound advance and get more and more techniques. But anatomy, got to know it. Okay, guys, got to understand at least a strong basic understanding of your anatomy and physiology. When I went through uni, my car travelling buddy was a particular gentleman who, just towards the end of 3rd year, he stopped me one day and he said, look, I can't ask anyone else about this but you. And he said, how does liquid get into the kidneys? I don't know the tube that goes from stomach to kidneys. And I had to actually stop and think about it for a little moment before I could come up with the answer. So I expect a level of knowledge better than I had at those particular times, okay? All right. So we're going to be learning it in basically a series of modules, okay? Some overview of our positioning there. By body systems, cardiovascular is going to be probably covered mostly in the tutorials. All right. It's important for all people involved in healthcare for abdominal imaging to be aware that the abdomen can be divided up in 2 different techniques. The first of these being the very, very traditional abdominal quadrants. The advantage of this, nice, easy to know system, okay? Very, very easy to remember which quadrant is which. It's been around for a long time, but the only downside of the quadrant-based system is that it doesn't really allow a great amount of exactitude for the patient description. So, for example, if the patient says, I've got pain, and the doctor says, roughly whereabouts is it? And the patient says, oh, look, it's in this region here. being able to say the patient's got pain in the right lower quadrant isn't really tremendously useful. It's a quarter of the abdomen. That could well be appendicitis, it could be small bowel, it could be large bowel. On a patient of hyposthenic habitus, it could be the distal part of the stomach, and so it's not very specific. So a second technique was devised utilising these 9 abdominal regions, and the nice thing about this method is the fact that you can be quite there's a high degree of correlation between pain in a particular area and a particular pathology. So it was more useful for communicating between healthcare professionals. Okay, that's the good news. The bad news is the fact that this naming system is absolutely ridiculous. Okay, the fact that the segment over the pubic symphysis is the hypogastric region. Yes, it is below the stomach, but it's nowhere near it. So the naming convention isn't very good there. So I do want you to know these regions, both in terms of quadrant and your 9 body regions, because it is something that you are going to have referred to you in the course of your professional practice. All right, surface anatomy. There are virtually all of the surface anatomy structures here you will have encountered before. In terms of midline structures, the one which is going to be most useful to you is often going to be the xiphoid process.
Sorry, with the 9 regions,
yes.
Would you like us to know what organs correlate to what region?
That will not be necessary. I would like for you to know the names of them. However, one of the things which will be covered in your Rad Anat and Path component of your online exam is that you will be asked to identify anatomical structures. Because some of the structures in the abdomen have got a very, very similar density, I may be asking you to, for example, identify the region of the origin of the appendix or something like that. So you do need to know where all of your anatomical structures should lie on a normal abdomen, but you don't necessarily need to correlate that to those region structures. Does that answer? Fantastic. All right, so surface anatomy. Anteriorly, the xiphoid, xiphy-sternum is going to be probably the most utilised one to be able to know whether or not you are centering over the midline. Yes, there is always the pubic symphysis, which can be utilised. However, and I'll say this once at the beginning of it and then we'll just leave it be. Pubic symphysis obviously is an area which should be palpated with the absolute maximum of gentle professionalism and communication. It is the only other reliable midline structure other than the xiphoid. We don't use the umbilicus ever, okay? It is just too variable a structure. When patients have had surgery, their umbilicus get pushed one side or the other just from scar formation. When patients reach a hypersthenic body habitus, particularly once they get into the really extreme levels of higher BMI structures, then it becomes an incredibly unreliable thing. Once we get patients who are really big, they will have a tendency for their own comfort to just have a preferred side for their abdomen to flop over to, okay? And so just utilising the umbilicus as a surface anatomy structure, it just doesn't work, so don't use it. Now that I've made that rule, I am going to break it in just a short period of time, but that one aside, we're not going to use it. Please recognise that when patients try to get comfortable on an X-ray table, lying completely supine isn't particularly much fun. It's not great fun on your own comfy bed at home, and on a fiberglass table it's even less comfortable. Patients will bring one knee up or the other just to try to rotate their body just a little tiny bit. And so I do want you to be aware that, again, particularly with hypersthenic patients, but with any patient, it's not enough just to be able to say that the centre of my beam is centred over the xiphoid or the pubic symphysis. You've also got to make sure that the patient isn't rotated as well. So for all of these projections, all of these abdominal ones, particularly if you have a larger patient, I do encourage you to go to the head end of the bed or the foot end of the bed and just have a look down the long axis of the patient just to make sure that they're not particularly rotated. Now, there are some bilateral structures that you can also utilise to be able to find out if your patient's rotated or not. You can, for example, put your thumbs over the patient's ASIS, their anterior superior iliac spine, and then stretch down to the tabletop and ask yourself, are those landmarks equidistant from the plane of the table/image receptor? So that's something you can do as well. But patients' abdomens are asymmetrical. We know the location of our iliac crest, we know the location of our ASIS. One of the things which tends to be a little bit challenging for students, particularly when dealing with larger patients for the first time, is to be able to know what is iliac crest/ASIS and what is greater trochanter. Now, those structures should be separated by 15 centimetres or so. However, in a larger patient, it can be easily confused. So what I tend to do with my larger patients is to start off with my hands on their hips over about the level of the greater trochanter, and then just sort of inch my fingers further north from that, going superiorly, so I can feel the indentation above their greater trochanter and then continue up, digging my fingers in as I go to try to palpate that iliac crest structure. So that's the way I do it, but you might find your own method for doing so. So those are the surface anatomy structures that we should be using for the majority of our abdominal imaging. Now that we've talked about how unreliable the umbilicus is, we're now going to utilise it as a structure. Here goes. McBurney's point is a point on the abdomen which doesn't have a specific landmark associated with it. McBurney's point is a point where if you were to draw a straight line from the patient's right ASIS to the position where their umbilicus should be, once you have got that straight line, you travel 1/3 of the way from the right ASIS to the umbilicus standard position. All right. So we've got right ASIS, umbilicus standard position, cut it up into thirds. This point here, 1/3 of the way from the lateral to the medial aspect, is McBurney's point. McBurney's point is the origin of the appendix. This is where a sonographer will start scanning when they want to have a look and see if the patient has got appendicitis. All right? McBurney's point is, as I say, it's breaking a rule. We're using the umbilicus location, but it is an important landmark because the correlation with tenderness on McBurney's point with appendicitis is a very, very strong correlative one, okay? So you've got a patient, queried appendicitis, you get your thumb, you dig it into McBurney's point. If you have to dig the patient out of the roof cavity, yes, they've got appendicitis, okay? It's a really simple rule like that. You don't even need an ultrasound. How to tell an AP from a PA abdomen. All right. On an AP abdomen, well, first of all, go back. Our iliac crests are not a completely flat structure. They have a slightly forward angulation. As such, when the patient is in an AP position, the divergent rays will further flatten out those iliac crests. And you're going to have iliac crests which have got a nice big roundy shape to them. All right? On the other hand, if the patient is in a PA position, those divergent rays will run close to parallel with the iliac crests, and instead of having a roundy shape, you're going to have that pointy shape to it. Okay? So, roundy versus pointy is how you tell an AP abdomen from a PA abdomen. Now, just a little side one here, just because I find it's an interesting thing. In our tutorials a couple of weeks ago, we talked about different locations of growth plates, and there's one right there. We've got a little physis line underneath that patient's iliac crest. You don't see them in all patients, but there is one there. So that is one you don't see very, very frequently, but a good case there. All right, so AP abdomen, they've got a roundy iliac crest. PA abdomen, they've got a pointy iliac crest. Please note that I am using AP and PA as my terminology here. I am not using supine and prone. As I talked about in the tutorials last week, we have to remember that the projection is based upon the location of the image receptor relationship, not on patient posture. All right, so there's a relatively small number of projections, but I'm going to be referring everything to the supine AP projection, so we're going to learn that one really, really well. Now, having said that, it's a really easy projection. Here's Cameron's short version of how to do an AP abdomen. Do an AP lumbar spine and open the collimation. There you go, done. You can now do an AP supine abdomen. For a supine AP abdomen projection, we start off with the patient in a true supine position, and we will make sure the patient is truly supine by a method such as palpating the crests to make sure they're equidistant from the image receptor. These projections will, in the majority of cases, be done with a straight tube that is perpendicular to the anatomy and the image receptor. Now, different radiographers will tell you different things about where the tube should be centered height-wise on the patient. Some of them will tell you that it should be over the patient's iliac crest. Some will say that it should be at the level of the lower costal margins, and I think it's between those 2 points. Now, having said that, I don't care. Okay, the reason why is because there are patients out there whose lower costal margins superimpose their iliac crests, okay? The distance between these two structures is going to be, on the average patient, I don't know, feel them on yourself, lower costal margins to iliac crest there, really dig your fingers in, and look, for majority of you, we're probably talking about 5 centimetres or something like that, so we're not talking about a huge distance there, okay? I tend to go between those two structures. I'll talk about the diaphragms in our critiquing in just a little second. 35 by 43 portrait on a patient of normal body habitus. Virtually all of these examinations are going to be done on the 75 kVp range. The larger the abdomen, of course, when we have patients who have got an increased body habitus, an increased BMI, it becomes a big challenge, because particularly with male patients, males have a tendency to put fat on over their abdomen, and it will be the most disproportionately large part of the body. And as we increase our KVP, of course, we know that our image is going to get more and more grey. So that's one of the big challenges in imaging, balancing the KVP versus the grey scale of the image. All of your abdominal procedures will be done with a grid, and 100 centimetre FFD is going to be appropriate in the majority of cases. Now, on abdominal imaging, we perform it with a suspended expiration. On a suspended expiration, the diaphragms will go more superiorly. On an average-sized adult, the length of the abdomen from the top of the diaphragm to the middle of the pubic symphysis will be longer than 43 centimetres. As such, a decision has to be made about how to go about fitting all of the abdomen onto a 35 by 43. And there are basically 3 options. Option number 1, don't do it expiratory, do it inspiratory. That's going to push the diaphragm down, lower the height of it, and you might be able to fit it on a 35-43. And I asked a number of radiologists why we don't do it that way, and the response was virtually identical all the way across the board, that it's substantially harder to interpret an abdomen on an inspiration just because there is so much more compression of the abdominal contents. So we do it on expiratory. So then it becomes a question of, if the whole abdomen doesn't fit on a 35 by 43, which bit do we cut off? Do we trim off a little bit of the diaphragm, or do we trim off a little touch of pubic symphysis and so forth? And once again, I asked a number of radiologists about this, and the response was unanimous. They said, trim off some of the diaphragm. I didn't expect that. I was expecting the lower structures to be something that could be more usefully deleted if you had to cut something off. But the response was basically stomach and liver imaging is best done by other modalities. So if you trim off a little touch of the diaphragm, it's not so much of a concern. All right. So as such, in terms of the criteria for an abdominal X-ray, you'll note that we've got as much diaphragm shown as possible. Now, in this patient in front of us here, we've got just a small amount there and a tiny, tiny amount there. The diaphragm probably curves, I don't know, approximately like that. So we've trimmed off a decent chunk. However, I am reliably told by my radiologist colleagues that that's okay. So there you go. So in terms of your critiquing, try to include as much of the diaphragm as possible. Sam?
Is that because, I guess, not all the time, but a lot of the time, the patients will come in also asking, the doctors are asking patients to do a chest X-ray, so you're going to get that lower part in the chest.
That's a big component of it. So Sam's question is part of the consideration there, the fact that a chest X-ray is often done as part of an abdominal series, and that is a big contributor to the mindset there. Chest X-rays are routinely performed very, very commonly with an abdominal image. Essentially, the thinking is that high diaphragmatic sort of level pathologies are going to be either a chest X-ray or can be assessed clinically more reasonably. So that's the mindset anyway. So it makes sense, of course, and we'll talk about some of our acute imaging of the abdomen in a short period of time, that there will be times when you think that as a radiographer you definitely should include all of the abdomen, including the diaphragm. If you feel that needs to be done, then yes, do so. Inferiorly, the mid-pubic symphysis. Ideally, we would have included just a little tiny touch more. The entire height from the superiormost to inferiormost point of view pubic symphysis is about 2.5 centimetres. Okay? What I would like for you to do is to try to include, there's two ways of looking at it, the top half of the pubic symphysis, or another way of looking at it is that if you were to draw the pubic symphysis, we have got our obturator foramen sitting in there. I always try to include from the middle of the curve of obturator foramen. Okay? That tends to be a good amount of inferior part of the abdomen. Now, the reason why I tend to use, you'll have radiographers say, oh no, so long as you've got a little touch of it on, it's acceptable. It's not quite. I'll show you the reason why. On this particular patient, you might be able to see just the very, very gentle outline of sigmoidorectal bowel there, but we can't get the inferiormost point, okay? Patients, particularly older patients, will have a tendency to have abdominal structures which are sitting lower, okay? Bladder, vaginal structures, bowel structures can often sit more inferiorly or prolapse further down, and so just including a little touch more than what you see here is ideal. Psoas muscle I'm going to talk about in a short period of time, in a little touch more detail. It's not seen on all patients, but in the majority of cases it is seen. And no rotation. How do we work out no rotation? First of all, symmetry of bilateral structures. Do the iliac crests look symmetrical? Is the angulation of our ribs symmetrical? Pelvis, obturator foramen, are they looking symmetrical? Once you've got those ones, then we can start looking at midline structures. And ideally, much like a spine projection, you should have the spinous processes sitting in the middle of the vertebral body. Now that I've drawn all over that abdomen, can anyone spot an abnormality on this patient's image? That is a possibility, but I was more looking at this thing. If you haven't spotted it, in there, looks like the patient's got spina bifida. Noticed that? Very, very subtle one in there. Haven't noticed that before. Shown that image for about 5 years. Ha. Abdomen should have a wide window width. It's totally and utterly appropriate for a long grey scale or wide window width. Okay? So don't be at all surprised if you have a very grey looking image. You'll notice on a lot of these patients that you should be able to see the soft tissue contours quite readily. Okay? You should be able to see, and not to put too fine a point on it, folds of tummy. Okay? Notice here we have got a crease of gas from where their tummy has folded up on itself. Okay, can you see that one bilaterally? So we have got a, well, being as delicate as I can, a tummy flab roll there, okay? And you can see another one here, and another one here, and another one here. And so this patient, I think, might be of a slightly generous proportion, okay? So seeing those soft tissue contours, and indeed folds of tissue, is entirely appropriate and good on abdominal imaging. We want a wide window width, okay? And indeed, what you might be able to see is, notice this one here, how we have got a denser lot of structures medial to these dots and softer ones here. So we have got fat here and muscle there. That's the sort of wide window width that I'm talking about, all right? So lots of structures should be seen. Markers should indicate the side of the patient. Generally speaking, I put the marker for an abdominal x-ray in the bottom right corner. I don't put it up the top because it's likely to go over more important anatomy such as liver or stomach. So pop it down on the bottom. All right, so covered that in a fair amount of detail there because it is an important projection to start off with. Any questions about any part of that so far? Great. All right. The PA abdomen is commonly performed in the prone position and will be prone for a patient undertaking conventional non-fluoroscopic imaging. Once again, we can assess the true PA nature of this patient by doing the crest equidistant from the image receptor. Prone abdomen projections are utilised for a number of reasons. Reason number one is it's better for the patient. The reason why I say that is because it has a substantially lower dose. Simply lying prone will compress the abdomen, less tissue to shoot through, and so you have got a slightly lower dose. So if you can, if all other things are equal and your patient's compliant, then prone imaging is not a bad way to go. Radiologists are more used to looking at an AP projection rather than a PA, so wherever you find yourself working, they might have protocols about that, but I will tell you that a PA has substantially less dose. Otherwise, the PA projection of the abdomen, commonly done in the prone position, is, and here we go, a supine but the patient's prone. That's pretty much it. Every other factor is the same. Our centering level, our centering point, our collimation, our grid, our exposure generally, our breathing instructions, all going to be exactly the same. Why would we do a prone position? In many examinations, it is necessary with contrast media to perform 2, 3, 4, 5, 6 projections of patients in different positions. So as a quick preview, one of the more radiographically projection intense examinations that we're going to be describing over the next few weeks is the bariomenema. Now on a bariomenema, you are going to do a supine, a prone, a left lateral decubitus, a right lateral decubitus, a prone with a 30-degree angulation, and a horizontal beam rectum. 6 projections, all of the same body region, just to be able to show the position of that residual contrast and double contrast areas around the abdomen. Okay, so it seems like a bit of overkill to describe all of these projections, but it is actually necessary for a lot of contrast-based imaging. All right. How should it look? Pretty much like an AP projection, except we've got our pointy iliac crests. Once we start introducing contrast into it, things will look a little bit more different even more. So, our criteria are very, very similar. Once again, show as much of the diaphragm as possible. Once again, show to the midpoint of the pubic symphysis / obturator foramen. Psoas muscle, once again, I'll come back to. But once again, wide window width. Now, you'll notice that on this particular projection that I want you to make a note of the marker there. Has that been done correctly? If we hang an image correctly, the page, when I say hang an image, that is to send it to the PACS or to literally hang a film on a viewing box, it should be in the anatomical position. So, one of two things needs to happen there. One, bad marker location, Mr. Radiographer, and it should be an L, or indeed, it hasn't been flipped and the right should be back to front. But one way or the other, that's bad. So take a big old pen and scribble through that, because that's some bad radiography right there. Now, on the topic of markers, I would encourage you to use markers obviously at the time of the examination, and also encourage you to utilise markers which indicate the patient's position. So if you've got supine markers, prone markers, LLDs and so forth, please do use those at the time of the examination. Don't try to remember which one is which. Marker use in abdominal imaging is actually quite involved because, for example, you might have a patient who comes in for a barium follow-through. Don't worry if you don't know what that is yet. We'll talk about that in upcoming weeks. But it might be necessary for you to put on, obviously, the patient's ID goes on the film, but there also might be a left marker, an erect marker, and a clock face marker to indicate the amount of time since the contrast was ingested. Okay, so it's probably one of the most marker-intensive body regions to image. So, we've done a supine projection, we've done a prone projection. Now the next one is the erect AP abdomen, and this is a projection which is utilised both in contrast imaging and it is used incredibly commonly in emergency department presentations. Okay? Now, when a patient presents to an emergency department with abdominal pain, the nature of their pain will dictate what projections are done. Generally speaking, the supine AP projection is considered to be the most useful in terms of radiological and physician diagnosis. However, there are particular pathologies that can't be excluded on a supine projection. As Sam mentioned before, diaphragmatic ones are one of them. As such, often an erect image is performed of the abdomen as well, and the reason for that is to basically see gas patterns. The gas patterns that I am particularly interested in when I undertake an erect abdomen is, number one, is there any gas underneath the patient's diaphragm, a pneumoperitoneum? The second one, which I am interested in, is are there any fluid levels which might indicate things like bowel obstructions, and we'll talk about that in the tutorials next week. Now, in an erect abdomen, there are a couple of variations that I want you to be aware of, so I'll mention those ones now. Number one, because an erect abdomen, here goes. In an erect abdomen, you will have one lot of radiographers who will say, you should be centering higher on the erect abdomen if you want to show the diaphragm and any pneumoperitoneum. It's a valid statement. You'll have some radiographers who say you need to centre lower because gravity is going to make the entirety of the tum-tum sink down with gravity, and so we should centre lower to show all of those abdominal contents. And then you'll have people who just go, no, centre where you were before. Whatever you do, it will be wrong. So here's what I'd like for you to do. Have a look at the patient's clinical history. If they're querying free gas under the diaphragm, centre a bit higher. If they're querying something like prolapsed rectum, then centre a little touch lower, or indeed make someone else do it because that's awful. But have a look at your patient's clinical history, and that will tell you how you need to adjust your centering height. However, in your exams, your centering point is going to be as per before, that is halfway between those lower costal margins and the iliac crests, okay? But do recognise there will be clinical variation. Right. Next thing. When you go out on placement and in your professional environment, you'll be told that an erect abdomen should be performed in the AP position, and you might also be told that it should be performed in the PA position. Now, there are reasons for doing it either way. Here goes. In an AP position, pros, it's closer to the comparable supine projection, and so there is a better radiological diagnosis. Great. The counter-argument is this. Patients who come in for an abdominal x-ray may well have had pain relief on board, may well be in pain, may well have cramping in their tummy and they don't want to stand up, in which case performing a PA when they can wrap their arms around the erect bucky is just a fundamentally safer way of doing it. Pros and cons either way. What I would like for you to do is to decide on your patient presentation the most appropriate way. Your default will be the AP, but I really don't mind, okay? If, for example, scenario exam comes around and you're asked how to do a projection on a patient, look, if the patient's cooperative, yeah, do it AP, but if the patient's in any way compromised, a PA projection is just fundamentally safer. The nice thing about a PA projection as well, once again, they'll push their tummy in against the erect bucky and you'll get a slightly lower dose again. So pros and cons either way of that erect.
If it was performed prone,
yes.
Would you just do a PA normally?
Yeah, I would try to have a little bit of continuity, but prone as the primary projection, how's that for alliteration, is less common. So yes, your principle is a good one, yeah.
Okay.
So this patient, you can see there, he's holding on to the erect bucky underneath. That doesn't feel very safe, all right, for patients. Give it a try when you're next in the lab, sort of hold on to the bottom. You feel as though you can tip forward at any time. Compare it to literally wrapping your arms around the erect bucky. And the PA, look, the take-home message is this. Yes, while the AP is preferable, if you've got any concerns about your patient safety, PA, okay? It is no less diagnostically sound. Literally the only advantage in inverted commas is that it has a presentation which is more in line with what the radiologist is used to seeing. There is no difference in diagnostic. Possibly so. Yeah, well, to give you an idea, and now I am talking about an anecdotal, non-assessable thing. Okay, I'm now talking about my clinical radiographic experience. I do 95% of my patients PA, okay, because I think that it's fundamentally safer. A lot of my patients are compromised. I think that giving them something to hold on to is great. And the other one is you have these patients who have got the abdominal cramping, and so what I will have a tendency to do is, people who are watching this on Echo or Panopto, you've got no idea what I'm doing at the moment. I will drive my bed so that the long axis of the bed is parallel with my image receptor, and then you have a patient who is a little bit compromised, a little bit dizzy or something like that, get them to swing their legs over the side of the bed, and then presuming that you've got your tube, your image receptor and whatnot set up, you can basically do a what? Grabbing on, taking the shot, down you go sort of territory. And I think that's a good way of getting good imaging with minimum patient concern. And you can almost wedge the patient between that erect image receptor and the bed, okay, so that they've only really got a few options of how to fall. So that can be a sound way of doing it as well. So is there going to be a change of culture? Probably. I would say that my radiological colleagues at John Hunter are so used to doing PA or seeing PAs that it's almost inconsequential. So yes, textbook, AP is the default, but I'm not making textbook radiographers, I'm making clinical radiographers. So if you've got any doubt at all, PA, all right? Here is an erect AP abdomen projection. I would like for you to notice a couple of things here. Notice the shape of the pelvis. When we are erect rather than supine, our pelvis will tilt very slightly, so because we're actually putting force down on it, okay? So it is quite common to see on an erect abdomen a pelvis which looks as though it has been foreshortened a little touch vertically. That's very, very normal. That's just what we are for being bipeds. This particular X-ray is one which is a beautiful teaching image because it shows a whole bunch of really interesting little subpathologies, which I'm just going to mention now while we're here. Number one, notice this sort of weirdness about the ribs, that it almost looks as though the ribs have got a joint at about there. That's because all of those rib structures medial to that point have calcified. That is a thing called calcification of the costal cartilage, CCC. Your midline ribs lower down are going to be a very, very softer structure. They don't have a high calcium level, but you can get a calcification of the costal cartilage down low. Second thing which is interesting here is have just a quick look at this image and see if you can find a fluid level or two. How many can you spot there? I'll have a count myself. I've got 23 fluid levels, okay. This patient needs to find a toilet, an iPad, and a lot of time because this patient has got some plans for the near future. Fluid levels in the abdomen are something which I want you to be able to identify quite readily. We're going to talk about this more when we talk about bowel obstructions in the near future, but I am going to describe a particular radiographic sign now, and this image is a great example of it. See this step-like bubble of bowel, how we've got sort of bubble, 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 bubble. That is referred to as the string of pearls sign, okay? Because it has an appearance somewhat like a necklace of pearls. Okay, that is a characteristic of a patient with a bowel obstruction. We'll talk about that more when we talk about our pathologies next week. All right. As I mentioned, on that erect AP abdomen position and our PA, it might be worthwhile to consider centering lower depending upon if we're looking at diaphragm or abdominal structures. So, what should we include? All the things that you have seen before, and markers to include which side of the body and the position the patient was in. If there are any fluid levels, they have clearly been shown, absolutely. And this lot of criteria is going to be essentially the same for all projections that we do from here on in which have a horizontal beam, Okay, so it doesn't matter if it's a left lateral decubitus, right lateral decubitus, any of those ones. If it's got a horizontal beam, these criteria are going to be consistent through pretty much all of those projections. Okay. PA erect abdomen. Okay, step one, make sure you've got your best blue undies on. Step two, the positioning is pretty much exactly as you would have expected, turning the patient around from an AP erect projection. I don't have the patient's arms down by their side. The reason why is patients have a tendency to want to have their hands behind their back a little bit or over towards their groin a little touch. And if you've got a patient who's able to hold on to something, get them holding on to something, okay? There's nothing to lose from having the patient's arms wrapped around, okay? So I would most assuredly have my patient's arms wrapped well and truly around that erect bucky. Otherwise, as before, do you need to centre high because you're looking at diaphragm? Do you need to centre lower because you're looking at prolapsed or lower lying structures? But otherwise, the projection is as before. You'll notice that we're starting to accelerate now because we've covered the AP supine abdomen in such detail. What should it look like? Well, something like that. This is a nicer one. This is the sort of centering I like to see, so sort of at the curvature of the obturator foramen. Notice once again, because it's an erect patient, our pelvic tilt has made for a shorter pelvis. It has got a much shorter structure. And this particular one, this patient I suspect might have been a little bit of a shorter patient because we've included not only a big part of the obturator foramen, but we've actually got clear diaphragm, both sides, so that's a fairly rare one. If I saw something like that, one of two things has occurred. Either it's a short patient or the patient has taken an inspiration, okay? If I saw something like that, I might even ask the patient, did you take a breath in or did you breathe out? That's not, if the patient had taken an inspiration because they weren't paying attention, I wouldn't repeat it for that, but if I did have further imaging, I'd counsel the patient that, you know, next time around it's breathing out and holding it out. Nothing wrong with coaching your patient for breathing techniques. And what do you know? All of those similar things. Once again, all of our horizontal beam things are as per before. Right. We have a patient who comes in from the emergency department and they have a oh, sorry, Zach.
If you are centering between the lower dorsal margin and the iliac crest,
Yes.
and on your image you don't include the pubic fin
Yes.
in the middle of it, or the diaphragm, is it repeatable?
In an exam situation, yes. However, I would, in the clinical context, ask myself, what does the clinical history say? If, for example, the clinical history was queried bowel obstruction, the vast majority of the bowel contents are going to be on your image, so I wouldn't repeat it. If it was queried pneumoperitoneum, absolutely I would. So as far as your exam answers are concerned, you should include either a strip of the pubic symphysis or diaphragm, but in the clinical context, it's all about what are we trying to show. A bit of a cop-out answer, that one, but it's the best I've got. You know what, we'll actually take a break for a couple of minutes and we'll come back in to our left lateral decubitus projections, give you a chance to stretch, buy coffee, de-stress after the physics. All right. Let's imagine a circumstance where a patient presents to you from the emergency department and they are querying something like a perforated bowel, a pneumoperitoneum or something like that. Your patient is unwell. They've got abdominal cramping, they may have had pain relief and things like that. But you need to perform at least one view to be able to show fluid levels. You've done your supine projection, that was easy enough. You've managed to get an image receptor underneath them, but you need another view. You need a horizontal beam projection. Even with that attempt of swinging the legs over the side and standing your patient up, it still just seems unsafe for you. So you decide that you're going to do an alternate projection. That's where the left lateral decubitus projection comes in. The left lateral decubitus projection should be considered as an alternate view to an erect abdomen if the patient is unstable, in pain, can't stand up, all of those sorts of things, okay? Now, the left lateral decubitus abdomen can be performed with the patient in an AP or a PA projection. Remember that a left lateral decubitus means that the patient is lying down on their left side. Okay? They can be lying down on their left side facing toward the image receptor. That would be a PA. Or they can be lying on their left side with their back against the image receptor. As you can see here, that would be an AP projection. All right? Which one's better? Well, depends on the patient presentation. If you've got a patient who is cramping up and bringing their knees up, it might be better to do it in an AP projection or something like that, so the knees aren't going to be quite in the way, but it really doesn't matter too much. Okay? If you think your patient is going to get some value by having their arms wrapped around the erect bucky, then maybe PA might be better. So that is going to be one at your discretion, and that's often going to be based about how the bed got pushed into your X-ray room, for example. So, the left lateral decubitus position starts off with the patient in a left lateral position. Now, in this particular image, you can see there that guy is not lying on a mattress, he is lying on some sort of sheet of fiberglass, and the patient's not going to be doing that. They're going to be lying on a mattress specifically designed to annoy radiographers. Okay, they're going to be soft and they're going to be comfortable, and the patient is going to sink into the mattress so far that if you are doing this on a bed, you're going to get a fair amount of mattress projected over the inferior most part of the body, that is the left side of the body. That's a bummer. So ideally it should be done on the X-ray table. So now we have a slightly paradoxical statement, because on one hand the best imaging will be transferring them onto the table, but these are patients who are not likely to want to go onto the X-ray table. So it's all going to be the best you can manage sort of territory. For those of you, I'll talk about a particular type of mattress which is being used a fair bit nowadays, particularly in public health. The eggshell mattresses. I don't know if you've seen these. They're a black mattress which basically has some gas or air-filled little bumps all the way through them. They're supposed to be really, really good for patient comfort, which is great, and they're a nightmare for X-ray because the patients sink in even more, and there's like a couple of dozen bumps of gas-filled artefact all over your X-rays, so that's going to be slightly annoying there as well. So just be aware of those. So, a patient is in a left lateral position, and their arms, I have a tendency to put them in what I think of as being the prayer position, that is arms up and away like that. However, depending upon the patient presentation, it might be safer for them to hold onto the side of the erect bucky or to have it behind their head, whatever's going to be stable for the patient. I tend to have the knees slightly flexed because if the legs are completely straight, it's easier for them to roll off from their true AP or PA position, so a slight degree of knee flexion there. It's a horizontal beam projection perpendicular to the anatomy and the image receptor, and our centering point is once again mid-sagittal plane halfway between lower costals and the iliac crests. The image receptor here, you'll notice that I've said 35 by 43 relative to patient orientation. So it runs down the long axis of the patient, but because your patient's lying down, it will be in a landscape position. Okay, everybody happy with that? Okay, long axis of the film, long axis of the patient. And if you are doing it against the erect bucky, yep, we've got no problems there. If you are using a stationary grid, you need to be certain that you have centered well, because it's very, very easy to get grid cut off with a stationary grid if you haven't centered well on these patients. All right. Now, so far I've been talking about the left lateral decubitus projection, and I might well have a Kit Kat in my bag for the person who can tell me why we do a left lateral decubitus rather than a right lateral decubitus. Great stuff. Oh, we've got a half hand. Hit me. Sorry? Heart shadow is a lesser consideration. It's probably not a Kit Kat worthy answer, but it is about asymmetrical structures. It's this. Ooh. Is it? Ooh. Now we're getting somewhere. Tell me about fluid levels. I owe you a Kit Kat. I'll have a ferret through my bag in a short period of time. Amy's right. Because we are attempting to ascertain things like a fluid level or free air under the diaphragm, we want to be able to see gas levels. The stomach is a structure which should have gas in it, and so what we do is by doing a left lateral decubitus, exam question coming up, pens ready, we perform a left lateral decubitus for two reasons. Reason number one, the stomach will be on the left side, and so we know where that gas is. Whereas, and this is the important bit, any other gas will rise to the right side and be shown against the homogeneous density of the liver. All right?
That's what you might confuse, like, free gas within the abdomen.
Exactly. That's exactly what it is. So on this one, we'll do just a little quick drawing here. Left lateral decubitus, our stomach is on our left side. So if we saw some gas in this location here, we could be confident that it's stomach because it's been projected down towards the patient's left side. However, if the patient had some free air, a pneumoperitoneum, some gas that shouldn't be there, then that gas is going to collect something like that, okay? And by having the liver be this big, homogeneous, dense structure, any pneumoperitoneum is going to be projected quite clearly against that one because the gas is going to rise, okay? So that's the reason why we do a left lateral decubitus. Now in this projection, very, very useful projection, okay? Once again, if we have got fluid levels in the abdomen, we are going to see them nicely and clearly here, okay? This projection, you can see some sheet which has been projected over the patient there. This is actually still very, very well performed projection because it's very, very common for you to have sheet levels up to about here sort of territory. So it can be, if the more comfortable the mattress, the worse the radiography is basically the take-home message for that particular part of it. So that's our left lateral decubitus projection. In terms of criteria, show as much of the diaphragm as possible. Yes, absolutely. You'll notice this marker use has been quite good. I would actually take it a little touch further, and I would additionally put a left marker or a right marker, one or the other, Don't need to put both markers on, but I would put one or the other on that projection as well. I have a tendency to use the left marker for it, just to make it clear which decubitus it is. All right, so that's our plain imaging to start off with. We are going to be talking about projections such as the right lateral decubitus in our gastrointestinal studies starting now. Racing through. I'd like for you to know the relative locations of the nasopharynx and the oropharynx. You need to know how they join at the back at the laryngopharynx, and hopefully from your studies of the cervical spine in semester 1, you'll know about the location of the epiglottis and what level that should be. One of the things which is quite difficult for radiographers early on studying the gastrointestinal system is that there are all sorts of regular bumps and indentations in a lot of these structures. So for example, it's very, very common to have a irregularity on the left-hand side of the patient's esophagus, just from the virtue of the fact that the aortic arch compresses up against that structure, for example. So you will see lots of bumps and irregularities in some of these structures when they're outlined with barium. So, gastrointestinal system starts off with the mouth cavity, oropharynx, nasopharynx, joins at the back at laryngopharynx, goes down to the esophagus and trachea, but our trachea is part of our airway, so we're ignoring that from this point in. Then we go into our middle point, and we have got our stomach, small bowel, large bowel, into the sigmoidorectal bowel, and the anus. In our small bowel, we have our subdivisions there of our duodenum, jejunum, and ileum, and in our large bowel, we have got the ileocecal valve, cecum, coming up, and we have got our ascending colon into our hepatic flexure, transverse colon into our splenic flexure, descending colon, and into the S shape of the sigmoidorectal bowel. In addition, we have got our vermiform appendix. The appendix is most correctly referred to as the vermiform appendix. Vermiform means worm-like. There's our trivia for the day. All right, in terms of surface anatomy, all of the surface anatomy structures that we have considered so far are current and appropriate for our gastrointestinal system. Right, now, earlier on we were talking about divisions of the abdomen, and the question was asked about, do we need to know what anatomy sits in which region? No, but I do need you to know where all of your anatomy sits. So for example, just take a moment there, and I'd like for you to feel comfortable knowing or being able to locate each one of those structures. So starting off with the stomach, in this particular patient, I think that this patient is of a medium build. Okay, the reason why I say that is because patients who are Cameron shaped, the stomach is a virtually horizontal structure. Okay, patients who are of a medium build, the stomach tends to be on approximately a 45-degree angle, whereas if you have a patient of a hypo or asthenic habitus, the stomach is a virtually vertical structure. So you can hopefully see stomach outline there, and we should be able to see some indentations of those rugal patterns of the stomach, and the stomach is going to exit at the duodenum, and then it will go around the curvature of the duodenum. Can we see it much past there? No. So what we've got here is a whole bunch of small bowel. We can't see it at the moment. The next lot of gas-filled structure that we can see is going to be the gas-filled structure of ileocecal into the ascending colon, and then maybe part of the transverse. Is there a bit of descending? Not too much, and a bit of sigmoidorectal. However, when it comes time for your exams, I'm going to be asking you, as I mentioned, to not just to be able to identify the structures which are immediately visible on an X-ray, but in addition, I'm also going to want you to identify the appropriate approximate region of such structures. So, for example, if I were to ask you to identify the kidney, the left kidney, well, we've got a little bit of an outline there, But on the right-hand side, where is it? Maybe there's a little touch of it there, I don't know. But I do need you to know where its native location would be, okay? Cardiac sphincter, by the way, is the name of the opening of the esophagus into the stomach. Don't know why it's called a cardiac sphincter, but there you have it. Now, once we apply contrast to the examination, then hopefully things become a lot more evident, but I want you to be able to identify structures, both contrast and non-contrast. All right, moving on to barium. Here goes. When the following information is anecdotal and is non-assessable. Go back in time 20 years, 25 years, when I first started radiography. When you had a new radiologist starting, the first area they went to was fluoroscopy. They learnt radiation safety there, they learnt a lot about their anatomy in there, and they also learned a lot about team membership in there. However, over the course of the last 10 or 15 years, the culture has changed quite a bit, and the culture has moved to radiologists' first area of knowledge being CT. And there have been a whole bunch of influential factors on that, but one of which being that the sooner you learn CT, the sooner you can be on call for these radiologists. So that has been an influential factor there. But many radiologists have become a lot more skilled with CT over the last 10 or 15 years, and it means that one area which has suffered a little bit has been fluoroscopic procedures. As such, when it's middle of the night and a doctor comes down and says, I need to investigate some particular gastrointestinal pathology or something like that, a lot of radiologists will now send the patient for a CT examination rather than a fluoroscopic examination because they feel more comfortable with interpreting CT examinations, right? The dose of a CT is comparable to a fluoroscopic examination, but if you've got a skilled operator in fluoroscopy, fluoroscopic doses can be substantially lower, okay? So at this time, we are probably using a higher dose than we need to in some of those cases. However, the slightly better news is that some of our radiologists are becoming more skilled in ultrasound, and so there have been some greater referrals into non-ionising radiation. So there is a little bit of good news there as well. So that is an anecdotal statement, but returning back now to actual material, it does mean that a lot of the things which I'm going to be teaching you over the course of the next couple of weeks with our abdominal studies, particularly our interventional and contrast-based examinations, means that we are at a time of cultural change, okay? Don't be at all surprised if you go out on placement and you are told, no, there is absolutely no reason why you guys should be learning the barium enema projections. It's an old, outdated examination. We do all of ours now with CT colography. You might be told that. On the other hand, you might have a centre that says, no, we don't do CT colography because it has a lower sensitivity, it has a higher dose, and has a higher waiting list, and is a lot more user dependent. So no matter where you go, you'll be told that I'm wrong. That's okay. So when I'm teaching you these barium procedures, please do recognise that this is all based upon what I believe to be the most current, safe, contemporary practice, okay? As such, it will be your accessible answers, but there will be cultural change. Okay, so I'm going to teach you the most common one, an emphasis based on teaching you more rather than less. I have not got a lot of time for the mindset of it's fluoroscopy, go in, hit the reset button when it beeps and otherwise start texting, okay? I've got no time for that mindset. I want you skilled in what you're doing. So gastrointestinal imaging pathway, up the top half all the way down to the bottom. Top half of the body, we're going to be using the barium swallow and modified barium swallow procedures. Middle part, we're going to a barium meal. Then we go into a small bowel series. And then after that, we're talking about barium enemas and DEF procs. The appendix is going to be just a very small thing that I'll mention, and mostly in the context of an ultrasound. The barium swallow. A barium swallow procedure assesses the swallowing mechanism. There are a whole bunch of reasons for doing so. Patients, for example, might be born with an anatomical abnormality, such as a fistula, which is an abnormal connection between two structures. However, one of the most common reasons for a patient presenting for a barium swallow procedure is because the patient's having difficulty swallowing. They have dysphagia. Dysphagia or difficulty swallowing can be as a result of muscle laxity, it might be as a result of tumour masses, it might be as a result of fibrous changes throughout the body, and all sorts of things like that. The most common reason for a patient having dysphagia nowadays is a patient who has had a CVA, also known as a cerebrovascular accident, also known as a stroke. When a patient has a stroke, one of the things which often gets compromised is their swallowing mechanism, and so a lot of these procedures are performed on people who have had a stroke and as such may have mobility issues. Now, depending upon the patient presentation, the staff involved in this procedure might be radiographer, radiologist and nurse, or it might be radiographer, radiologist, nurse and speech pathologist. A speech pathologist will be involved in the examination if it is an area where a speech pathologist can assist, and those post-CVA dysphasias are a prime example of it. Okay, so I'm going to start by describing the barium swallow for somebody who's just got, I can't swallow something, it feels a bit funny, and then we'll branch out into the ones where the speech paths are involved. And look, it might be for foreign bodies of the gastrointestinal tracts, reflux, or indeed, as it is commonly known nowadays, GORD, G-O-R-D, which is gastroesophageal reflux disease. Okay? In the old days, it used to just be reflux, and you'd be chugging down a bottle of Mylanta every day. Nowadays, it's more commonly referred to as GORD, gastroesophageal reflux disease. And you might have varices, prominent vasculature in the stomach, or indeed a hiatus hernia. Now, as mentioned before, I will be saying it one time here and assume that this is continuously the case for all of the following barium projections. If your patient has a known or suspected perforation, you will not use barium. You will use an iodinated contrast. Another lot of consistent things which we're going to be covering well in the first time around, and we'll just assume from here on in. All of the examinations following will have a fluoroscopic component. As such, your practice should be to include the following steps. One, you have had the patient positively identify themselves and to meet all those appropriate criteria. The patient will be consented now. I'll take a moment just to talk about this. Depending upon where you find yourself working, the consent process might be for the X-ray dose and or the contrast being given, right? So what might happen is it might be quite a formal situation where you go in and you say, Mr. Smith, we're going to be doing a barium swallow procedure on you today. The approximate dose that we're going to be giving you is about this much. We would like to give you this barium sulfate to drink, and that is a contrast which shows up in your tummy and allows us to see your internal structures a little touch more. Do you have any allergies? Do you have any questions? Do you have any issues that you want to raise with us? No? Are you happy for us to go ahead with this examination? Yes, I am. Okay? Some centres will discuss the dose, some centres will discuss using contrast, some centres will bunch it all together, and some centres won't mention any of those things. They'll just go, you happy enough, Bill? Yep, get up on the table. Now, I would advocate for you to watch the practice of the imaging nurses, radiographers and radiologists in the first instance so that you can build up your own technique of disclosing these things to the patient. Okay? Always practice ethically. Many patients for barium procedures have a very, very poor understanding of what they're going to have done. And if you say, do you know what you're having done? Yep. Can you tell me what you're having done today? Well, I'm having this drink. And that's it. Okay, and that's really about the limit of it. And folks, these patients, it's not... There are some absolutely crazy stories, one of which I'll share with you in a few moments, but it is not ethically sound for us to do something to these patients without them understanding what's happening to them, okay? And you need to communicate unambiguously, and some of the things which we're going to be talking about are going to be embarrassing, okay? We're going to be talking about poo and stuff like that. You need to be able to judge your patient, assess the level that they can communicate at comfortably so that they understand it. So don't just have one spiel of how you explain things. I worked with a radiology registrar many years ago, and he and I were walking this lovely old lady around to the x-ray room. Okay, Muriel, we're going to be doing a barium enema today. Yes. Do you know what that involves? No. Well, we're going to get this tube. Yes. We're going to put it in the back passage. Yes. And then we're going to put some liquid through it and take some pictures. Yes. Then, now Muriel has heard the back passage and she assumes that we're talking about the corridor of the hospital that we are walking through. Muriel, a few minutes later, has wondered why she has to come out with no underpants on and why this doctor's coming at her with this tube. Okay, so there will be times for you to use clinical language. There will be times when you will need to say, we are needing to put this tube in your bum. Okay, it will be in there for 45 minutes. Okay, and to use quite colloquial language that is appropriate for the patient to make sure they understand. Okay, so positively identified the patient. They have been consented at a level which they can understand. Take off all jewellery and foreign bodies and things that you can take off which are going to compromise the examination, big earrings, necklaces, stuff like that. Get them changed into a gown. I have a tendency to get patients properly changed into a gown rather than just the gown over the top of the t-shirt because barium goes everywhere. With every barium procedure, you are going to counsel your patient that in a way similar to the following. Mr. Smith, you're going to be having some barium today. It doesn't matter if it's the top down or the bottom up. Over the course of the next 2 days, I want you to increase your fluid intake. Try to have at least 2 litres of fluid for each day for the next few days. Your poo will be white. That is entirely normal. Be aware of that. Don't be freaked out about it. Okay? So you're going to be preparing your patient both before the examination and afterwards. Right. Room prep, appropriate standard safety and functionality, PPE for yourself and all of the other staff that are going to be involved. All of these barium cases, I'm going to be saying this very, very vague phrase of barium at a consistency at the radiologist's discretion. Some radiologists like to mix it themselves. Some radiologists will just say, whatever consistency comes out of the bottle is good for me. Some have this very, very exacting dilution level. Early on in your career, most fluoroscopic departments will have a chart or a table or a book which outlines many of the preferences for some of these things. And so it might be 800 mils barium, in brackets 500 mils water, 300 grams barium or something like that. So you will often be told the consistencies that people want beforehand. All right, so the projections which we're going to do. We're going to be having a look at the patient's esophagus into the first part of their stomach. So we're going to be doing a NILI and AP projection. We're going to be doing 2 NILI AP projections. That is, the patient's going to have in an RAO and an LAO position. These patients will have the X-ray tube behind them, the image receptor in front of them, so be mindful that that means that they're going to have their face right up against the image receptor, okay? If you've got a claustrophobic patient, just counsel them and, pat their hand and things like that. So, the reason why we don't do a true AP projection, why we do these slight anterior oblique projections, is because we don't want to superimpose the esophagus over the spine. So we're going to be rotating the patient. How much? Don't know. We're going to be rotating the patient sufficiently so that their esophagus is projected off the spine. In an RAO projection, the esophagus will be projected over the heart. In an LAO projection, it will not. And finally, we're going to be doing a lateral projection. Why are we doing a lateral? Well, because we can, one, it's handy to have orthogonal views, but also there are a number of pouches on the anterior structure of the esophagus which we want to assess. The second reason why we do it is because there is a fundamental risk involved with a barium swallow procedure, and indeed a lot of these procedures where we swallow barium. Here goes. The barium swallow procedure is one for a patient who has got dysphagia, or commonly that's a common presentation. If a patient has dysphagia, they have difficulty swallowing. No problem. If a patient swallows incorrectly, they can have nutrients, food and drink, go into their trachea rather than their esophagus. This is something which we want to investigate. So one of the first projections which we might do in a barium swallow procedure is the lateral, just to be able to make sure that there is no likely risk of the patient aspirating the barium, that is, breathing the barium in rather than swallowing it down their esophagus. So if you like, the lateral projection is performed first because it allows us to know whether or not that barium is going down the pharynx and into the trachea. If that happens, we know that this patient is a patient who is an aspiration risk, and it might be necessary to stop the examination at that time because obviously we don't want to fill their lungs up with barium. That's an ouchie. Okay? So we'll often start with the lateral just to assess the suitability of the patient for the examination. Okay?
I'm sorry, just with that, would be close to a PA projection?
Yes, functionally close to an AP projection. I mean, positionally close to an AP or PA projection, but the most correct one, yes, it's functionally close to a PA projection because it is a postero-anterior beam. So consider it close to a PA or AP projection is probably the most correct. So what do? We take images, approximately orthogonally, lateral projections and anterior oblique projections. We do so to see sufficient views of any potential filling defects. Have they got a tumour mass affecting the side of their esophagus? Have they got any difficulty with the swallowing process? Are we going to aspirate any of those materials? Have we got any reflux? Okay, so basically we want to show the oral cavity, the esophagus, and the first part of the stomach. Once the patient starts to have any concerns or difficulties with this from stomach onwards, then we're on to our next procedure, which is the barium meal. Okay, but our anterior oblique projections. Now, in these images, the first thing which I want to do is this. These are very, very infrequently performed prone. They are almost always performed on an erect patient. Folks, when you are enjoying your McDonald's milkshake, you very rarely lie down prone and sip it out of a straw like this. The reason why is because you are likely to get reflux. Okay? We'll talk about provoking reflux in a little moment when we talk about a barium meal procedure, but I do want you to understand that in the majority of cases these are performed erect. Okay? This imaging actually shows it against a standard erect bucky, but it will be done with a fluoroscopy unit. And this patient looks like they've been obliqued by, I don't know, about 10 or 15 degrees or something like that. So this value here is very, very variable based upon the primary objective of get that esophagus off the spine. So, Mr. Smith, we're going to be doing a barium swallow procedure on you today. The instructions and these instructions which you might be providing, the radiologist might be providing, the nurse, the speech pathologist, but you're all going to be on the same script so that you can encourage the patient to have a consistent method. Mr. Smith, we're going to be doing a barium swallow procedure today. What we're going to be doing is, in a moment, you are going to take a mouthful of barium and you're going to hold it in your mouth. I'm then going to count down 3, 2, 1, ready, set, go. And I want you to swallow when I say go, when I say 1, or whatever the prompt is. What they'll do then is, if it's a ready, set, go, the radiologist will probably start screening and recording on the set, okay, as opposed to the go, because we want to just have some frames of normal beforehand. So it's going to be, take a mouthful of barium, hold it in your mouth, swallow when I tell you to. And we will do that right anterior oblique, left anterior oblique, and lateral projections. Now, this is an important note, the number of frames per second. Now, I want to just take a little moment to explain two different concepts which a lot of students get confused. Here goes. In fluoroscopy, I mentioned that one of the most powerful ways that you can cut down on patient dose is to have pulsed fluoroscopy. Okay? If you don't need to be constantly irradiating, if you can get away with 5 frames per second, why not do that rather than 15 frames per second or just continuous radiation? Now, there are 2 important rates that I'm going to be talking about. We've already covered the pulse rate, that is literally how many pulses of X-rays are travelling through the patient every second. In addition, when we are recording the fluoroscopy, we might be recording it as one long video, or we might record it at a number of frames per second. Okay? When we are doing a barium swallow, we will be acquiring, that is, recording about 4 frames per second. Okay? Now, here's the rule. There's no point in irradiating more than 4 frames per second if you're only recording it at 4 frames per second. That's just extra radiation that's not going to be helpful. Okay, so I want you to recognise the difference between pulsed fluoroscopy, number of doses of radiation per second, and frame rate, number of images stored per second. They are different quantities. One of the things that a radiographer is going to be doing is to liaise with your radiologist, speech pathologist or something like that, and it will be of the nature of, Dr. Jones, I've currently got this set at 4 frames per second. Are you happy enough with that? They might say, yep, that's good, or, oh, this patient I'm going to be screening for quite a long time, so we'll cut it down to 3 frames per second, so to cut down on some dose. Or it might be, oh, this patient's quite healthy, we'll do 5 frames per second. Liaise with the radiologist about that. Where should you centre? The radiologist will do much of the centering for these examinations, but you should normally centre it around about T6, the middle of where you would centre on a chest X-ray. Okay. You'll notice that on this patient, they have the radiologist or the radiographer has collimated to a fairly narrow strip. Okay. How much do you need to collimate? It depends upon that patient's anatomy. Have they got a very, very curvy esophagus? If in doubt, 15 centimetres wide is a good guess, but it will be a variable structure. I always dislike this part of the lecturing part of the year because I seem to be giving you nothing but really vague pieces of instruction. It is just one of those things about fluoroscopy that it is so variable a thing. So I'm teaching you principles rather than definitive natures. Here we go here. So we've got a right anterior oblique projection here, and notice this indentation I mentioned earlier about the aortic arch. Okay, that's an example of a very, very normal looking esophagus, but they will have these bumps and indentations on it. Okay, so the aortic arch can compress it a little touch. The pulmonary vessels can compress it a little touch. I would have liked to have seen some slightly narrower collimation on this particular projection. I don't think we needed to go all that far out, but generally speaking, what should we do? We should show the entirety of the esophagus, and it should be demonstrated off the spine and over the medial part of the heart. Very vague statements, but that's because we're not the arbiters of quality control on these projections. All right. LAO. Once again, it's done supine on this photograph, but we don't actually do these supine. We're going to be doing them erect against the fluoroscopic image receptor. Obliquity, 35, maybe it's 10 degrees. Once again, take a mouthful of barium, hold it in your mouth, 3, 2, 1, ready, set, go, start swallowing, and we'll take those pictures, 4 frames per second, tink, 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 tink. After a while, you'll be like a metronome. You'll be able to judge how many frames per second fluoroscopy goes at just by the number of beats in your head. It actually gets quite interesting. I am the most non-musical person that you can possibly imagine, but I could become a reasonably good drummer just in terms of how regularly I can do a frames per second. What should it look like? Well, we should once again have a degree of the heart being there, but not so much as in the other oblique. The entire esophagus should be demonstrated. Racing through these ones now. Lateral barium swallow. So this one's a little bit harder because we have the arms in the way. So in this one, I wouldn't actually do the projection like this. What I would do is I would hand the cup to the patient, let them take a sip or a drink of the barium, hold it in their mouth, and then put both their hands on their head to get them out of the way. Okay? Now, that's fine if you want to show the inferior most part of the esophagus, but if you wanted to show the upper part, then it might be necessary to do them in an arms down projection. Okay? So the radiologist will often do 2 laterals, the idea being that we'd have the superior one with the shoulders down and the inferior one in that prayer-like position. Arms can be a little bit of a problem there. Left or right lateral. Left is preferred because it's going to bring the left side of the esophagus closest to the image receptor. 1 cup of holding the barium, but then moving it onto the top of the head or having them down depending upon which level you want to have a look at. and this is what it should look like. This radiographer is collimated to the nearest postcode. Let's maybe cut that down a little tiny touch. We can probably collimate it. What are you doing there? You've got soft tissue borders on all four sides. That's bad radiography there. Don't be afraid to collimate, okay? Having said that, when you've got a mouthful of barium and you're trying to stand still with your hands on your head, you do wobble around a little touch. So a little bit of generosity in your collimation, but nothing too crazy. Arms out of the thoracic region, otherwise you're going to be projecting that esophagus anterior to the patient's spine. All right, we'll cover the modified barium swallow projection and then we will call it a day. The modified barium swallow procedure is undertaken in all ways as a standard barium swallow procedure, except it will be undertaken under the guidance of the speech pathologist. The speechies will come down and they'll discuss the case with the radiologist, and it's tends to be quite an interesting culture and quite an interesting work situation for the radiographers, because what you are going to be doing is you're going to be simultaneously answerable to two different people. You're going to have the radiologist saying, we need this frame rate. You're going to have the radiologist saying, can we bring those shutters in laterally to collimate in a little touch more? And you're also going to have the speech pathologist telling you what things you need to annotate or record on the film. So it is a little bit of a juggling act there. When a barium swallow comes in, be organised, have a notepad and paper nearby, okay? In the early parts of your career anyway. So, how does a barium swallow vary? One thing which I didn't mention before, but it bears repeating, when a patient is having a barium swallow, barium meal, barium follow through, anytime they're drinking barium, have a wipey cloth, a wet wipey cloth nearby, because it is, as I say, physically impossible to drink barium without getting it over the bottom half of your face, most of your neck and possibly your eyebrows, okay? So you'll be a lovely radiographer if you hand that patient a nice wet cloth, okay? So be nice to your patients. Now, a modified barium swallow procedure is in all ways like a standard barium swallow. However, the materials that we give the patient to eat or drink vary. When a patient presents with for a modified barium swallow procedure, the majority of cases is a patient who is post-CVA, post-stroke, who is having difficulty swallowing. That difficulty in swallowing will often be linked with particular food or drink types. On an initial consultation with the speech pathologist, this patient will go in and they will say, look, most of the time I'm really, really fine, except if I'm eating something dry like crackers or Wheat Bix, I still feel like I'm going to choke. Poltergeist. Anyway, on the other hand, it might be the moment I drink thin fluids, I'm fine, but thick fluids, I start to feel as though I'm going to choke. Okay? So what we are going to do here is, under the guidance of the radiologist and the speech pathologist, is we're going to try to, I guess, gently provoke a swallowing difficulty. We're going to watch as a number of different foods and liquids are swallowed by the patient, and what we're going to do is we're going to watch very, very carefully to see if the patient is approaching a point where they are more likely to aspirate, that is, breathe in the barium, rather than swallowing it. All right? So what do? We have got a whole bunch of different foods, and these different foods are going to be coated with barium. There are particular things which are more likely food products to be brought in: Wheat Bix, crackers, mixed fruit, jelly, thin fluids, thick fluids, marshmallows. Okay, they seem to represent the majority of food consistencies, and it's going to be those consistencies which provoke that feeling in the patient. So what it is at the start of the case, it's going to be a negotiation between the radiologist and the speech path. The radiologist will do an initial, very, very probably a thin barium lateral projection to make sure the patient isn't aspirating from word go. Then once that's done, the speech pathologist will work their way through different food consistencies. It might be very, very thin barium. Right now, let's try some thicker barium. Now we're going to get a dry Weet-Bix and we're going to smear barium all over it and get you to crunch that one down. I don't know how anyone doesn't chunder. I know I would with a lot of enthusiasm if somebody gave me a barium-coated Weet-Bix, but nonetheless, here they go. Now, here's the important bit. You'll be answerable to the radiologist in terms of pulses per second and frame rates captured and things like that. But you will also be listening very, very intently to the speech pathologist because they will be telling you what food consistencies they are giving to the patient. It is commonly the job of the radiographer to record those consistencies. It might be a paper-based form where you write at 17 seconds, Weet-Bix. At 35 seconds, crackers plus barium or something like that. However, with a lot more fluoroscopy units turning to a digital environment, it might just be as simple as a drop-down menu, okay, which is basically thin fluid, thick fluid, Weet-Bix, dry crackers, blah, 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 blah. But what you must do is to make sure that the speech pathologist who's going to be focusing on the patient after the examination can come back and go, right, I'm watching Mr. Smith's swallowing mechanism here, and I can see that when we have given him Weet-Bix, that starts the aspiration process there, so we're going to stop that. You know what I mean? So you need to annotate the thickness of barium plus or minus the foodstuff / nutrient being given, okay? What is the recipe being given to the patient at any particular time? With that modification, a modified barium swallow is the same as any other barium swallow. So modified barium swallow includes a speech path, different foods and fluids, and the radiographer recording such things. All right, bit of a drudge to get through that first lot of our abdominal imaging material. We are going to accelerate quite a bit more over the course of the next few weeks, but for the moment, I'm thinking that you guys could do with a de-stress, a refreshing beverage, and to not think about physics for quite a little while now. Thanks, guys, and I'll see you soon.